All right. Good morning. Can you all see my screen?
Yes.
Yes, perfect. Sorry, subaxial
Okay.
cervical. You got it.
So I'm Andrew Johnson, one of the Navy residents. That is, it's a pleasure of rotating here with you all. I'll be talking about subaxial cervical spine trauma. So just real quickly, we'll go over kind of some basics and classification, and then get into initial and treatment, also treatment of these injuries, and some of the research backing that. So these injuries happen in about 3% of patients sustaining blunt trauma, and like most orthopedic injuries, have a bimodal distribution, with younger, high energy patients and high energy injuries, and then older patients with lower energy injuries. A lot of these happen down in the lower aspects of the 50% from 5 to 7, and then 17% actually at the 7 to 1 cervical thoracic junction. Motor vehicle accidents and falls are pretty common. So the cervical spine is unique in its motion, and then also obviously has the spinal cord directly adjacent to a lot of these structures that can be injured. So looking at that, we have our guidance or goals and treatment is one, preserving and or recovering as much neurologic function as possible, as well as restoring or maintaining stability. So looking briefly at the anatomy here, on the right side, you can see our vertebrae as well as our disc, uncovertebral joints, and then obviously the presence or proximity of the neural elements and vascular structures. And then on the lateral on the left, this gets into a little more of specifics here. We can look at where Haldsworth and Punjabi talked about the two different columns, the anterior and posterior, and the anterior column, including the ALL, the annulus, the anterior annulus of the disc there, the bodies and transverse process, and the PLL, and then the posterior, including ligamentum flavum and the facet, pedicles, lamina, spinous process, posterior ligamentous structures. So these all come into play, as we'll talk about here, and those structures often can be either directly visualized or inferred from the relationships of your bones on your x-rays, and then, as we'll talk about, CT scans and other advanced imaging that can be used to evaluate these structures. So there's many different types of injuries and how these relate, like we said, neurologic injury and stability. So throughout recent times, there's been many attempts at classifying these to help guide our treatment and provide a basis for communication between surgeons and treating physicians, from Holdsworth, Allen, and Ferguson, then modified by Harris, the White and Punjabi checklist, the 4-column, and then what I will get into a little more today is the SLIC and the AO spine classifications. A lot of these were initially the earlier classification schemes talked about morphology and inferred mechanism of injury, which had some guidance for treatment. However, there was a significant amount of variability and not great inter-observer reliability between these, which is why we had these attempts, as I'll talk about.
Hey, Andrew, give me 1 second. Can everybody mute their phone besides Andrew? Thank you.
Mainly in Utah, my Utah guy.
I think it's background noise. Who is Andrew? Are you in the? Where are you, bud?
I'm in the surgeon lounge. I can try to go somewhere a little quieter. 1 second, I'll just go on the other side. Okay, should be a little quieter over here. So the subaxial cervical spine injury classification system, or the SLIC, is fairly recent, 2007, from the Spine Trauma Study Group. And this was a combination of the literature review and then expert opinion, retrospective review applied to their cases to try to create a more useful classification system that had better inter and intra-observer reliability, as well as some guidance for treatment. So going through it here, we talk about the injury morphology, the evidence on imaging, and then the integrity of the disco-ligamentous complex in the anterior and posterior ligamentous structures, and obviously with the disc, and then the neurologic status of the patient. So combining these, then they found that with less than 4 or 3 or less points, these patients were treated non-operatively or recommended to be treated non-operatively, and 5 or greater operative treatment was indicated, and then the 4 was the surgeon's preference. And we'll talk a little bit later about some of the further studies looking at this, and found that these treatment recommendations were pretty good going forward, but getting a little more into the injury morphology. If they have no injury noticeable, there's 0 points. For a compression type injury, including burst, you have the height loss through part of or the entire vertebral body, disruption through the end plate, and this could include compression, sagittal or coronal plane fractures, teardrop or section compression fractures, as previously described, and possibly undisplaced or minimally displaced lateral massive facet fractures. And then in the same category, but more severe, would be the burst, and you get an additional point with fracture through the entire vertebral body. And distraction, anatomic dissociation, vertical access, ligamentous disruption propagating through the disc space and into through the facet joint. So for an example of facet subluxation or dislocation with posterior element fractures would go into this category. And then translation rotation, again, more severe, include unilateral, bilateral facet fracture dislocations, separation with the fractured lateral mass, displacement, and bilateral pedicle fractures. And then going through the disco-ligamentous complex again, if this is disrupted and getting more additional points here, that indicates a more unstable injury. And then the neurologic status, which would be probably first most important factor in these patients, and the greatest influential predictor of ultimate treatment and outcomes, get more and more points noted, similar to the TLIX scores, that a complete injury actually has less points, and you get more points for an incomplete injury, with the idea that there is still something more you could do to potentially improve or stop further degeneration of that patient's neurologic status. So initial studies of the SLIC showed greater than 90% agreement between the scores and treatments. However, some further follow-on studies demonstrated more poor intra-observer ratings, mostly regarding the morphologic classification. So the most recent classification system is the AO Spine. This was published by Vaccaro et al. in the European Spine Journal in 2016. So this looked again to try to better describe the morphology and have better agreement amongst evaluators of these injuries, and then still wanted to include some of the good things of the SLIC classification that helped to guide treatment, including that they have the neurologic status and the case-specific modifiers here. So Going through it, neurologic status, as you see there, and then the patient-specific modifiers, either ligamentous complex injury, disc herniation, which went into that distal ligamentous complex from the SLIC, and then some other things that weren't discussed in SLIC, like such as the presence of dish or ankylosing spondylitis, ossified PLL, and general stiffening or metabolic bone disease, as well as vertebral artery anomalies or injuries. So this initially, again, their initial study showed some great reliability and reproducibility, less so in some of the more rare subtypes. And then a recent, in the bottom right-hand corner, 2020 in September article, again demonstrated improved reliability of the AO spine classification compared to some of the earlier ones. And to get into it a little more specifically, but we have the compression type injuries in type A with 0 through 4, increasing severity, and then the tension band injuries, so the B1, which was completely bony posterior tension band injury. They found very few of these actually in their initial classification study. And then the interesting thing here is that the set injuries are completely their own categories. You can see there with the F, and then bilateral injuries and any translational injuries, even if it is, comes from one of the other types, either tension band compression or set types, it would automatically go to the C category, and then you could use the other modifiers to further describe it. So now that we have some idea of how to discuss these amongst ourselves and some guidance and treatment, we'll go through that. So initial management with all trauma starts with ATLS, important on the scene or in the initial trauma bay. As you can see in the imaging here, that also that ATLS protocol, not just for us, but for everyone, including first responders, includes stabilization and protection of the cervical spine. When you're initially evaluating the patient, you want to take note of the cervical posturing, not posturing, but the posture in which they're held. Subtle changes or rotation could give you a clue of potentially something sort of like a unilateral facet dislocation, which is sometimes missed. And then one thing to note, you need to take careful note of is patients that talk about these stiffening metabolic conditions such as dish and ankylosing spondylitis, or that have a acquired and now kyphosis that is their normal. So the picture on the right was from a paper discussing that this patient who had injury and was stabilized with standard C collar. However, by forcing the patient into extension, they're actually extending and worsening or distracting further his injury secondary to his kyphosis due to his ankylosing spine. Also, especially in the patients, in any patient, there is a high incidence of non-contiguous injuries, but especially in those special circumstances with metabolic stiffening, then we would want to ensure to evaluate the entire spine. Again, initial management side is a discussion of closed reduction of facet dislocations. This has some controversy or difference over time in the literature, but I think it is fairly well accepted or recently that for patients that have a neurologic injury that are awake, then a awake closed reduction should be attempted to minimize their neurologic injury or increase their chances of recovery as soon as possible and not getting an MRI prior to that. The concern and thought of getting MRI is if there is a large disc fragment that you could potentially further push this into the cord and cause further damage with your reduction. And that is the purpose of the modifier of patient being awake and able to tell you, or you can examine them and see if they're having worsening neurologic function. If the patient is unable to respond, then that gets into a little more controversy whether an MRI is needed, but I would err on that side before proceeding with the closed reduction at this time. So other initial treatments, steroids. So there has, again, been some changing thought processes and guidance on the use of steroids in patients with acute spinal cord injury. So fairly recently in 2017, new guidance with clinical practice guidelines was put out saying that any patient over 8 hours from injury should not be given steroids. And then that they weekly suggest that there is some possible improvement in neurologic function, and therefore that it's reasonable to have a discussion and possibly use a 24-hour infusion of high-dose steroids in patients within the 8 hours from injury to treatment, but offering 48 hours, as done in some previously reported studies, did not offer any improvement. They do not recommend that due to the increased risk of all the side effects of steroids treatment shown in these patients, such as GI issues, pneumonia, especially decubitus ulcers, and even death. So there are some changes here from, there used to be a less than 3 hours to presentation, use that 48-hour infusion, so that the recommendations now are not to do that. And then looking at some even more recent data, this was a 2020 meta-analysis looking at, again, another few studies that have been published since that. This is out of Boston and Harvard, however, was published in a online open access journal, but not to go take this too seriously or change our practice at all, but they found no difference even in the less than 8 hour group. So again, calling into question the efficacy or the use of this, especially in comparison to the significant side effects. So as we're moving here, radiographs or imaging studies to evaluate these injuries. So things start with radiographs and orthopedics, AP lateral and odontoid views would be our standard basic cervical spine x-rays. It's important to note that there can be some difficulty in obtaining that C7T1 view. However, as we discussed earlier, up to 17% of injuries happen at that specific level. So it is important to get that if you're relying on your x-rays. There has been some discussion in the literature about flexion extension views having, as we use for other conditions, being used in this trauma setting. However, even in the awake neuro-intact patient, they will often have spasm, limiting the usefulness of these studies. And in the patient that has altered consciousness or unable to comply with the exam, there has been some discussion of a passive dynamic fluoroscopy with flexion extension views that can have some meaningful information passed on. However, this would again be somewhat risky maneuver and must be done with the utmost caution. Another known that at least 30 degrees of angulation has been described as being needed to get any use out of these exams. So more commonly today in the trauma setting, a CT has been used, has been shown to be 99% sensitive, 100% specific in some studies. And as well as in most centers today, very efficient to get these evaluations, exams completed. So that has become standard. Then moving into MRI, so there has been also some discussion in literature of whether an MRI is needed and or useful. So going to the, is it needed? So in a patient who is obtunded or comatose and you're unable to get a neurologic exam, was one thought this might be needed. A study recently done showed that there was 21% of patients with a normal CT had some findings on MRI. However, with a completely normal CT in that study, none of these injuries ended up requiring surgery or change management at all. So their evidence their conclusion was that it was not necessary to clear the cervical spine with MRI in that patient population. Another meta-analysis published that same year in 2008 called MRI the Gold Standard. This was more referring to the fact that a negative MRI in their study had a 100% negative predictive value. So it effectively rules out the injury, but that is not saying it's necessarily needed, I would say. But this is different compared to getting an MRI in a patient who does have an injury visualized on X-rays or CT. So this study of MRI in acute cervical spine fractures, they did find that the initial information provided by the MRI 48% of the time led to change management of 39% of the time. So as we talked about in the classification systems, the integrity of the ligamentous complex, posterior ligamentous complex is important for deciding the overall stability of the spine and planning your surgery or the need for surgery. However, only 19% of those changes in management were due to the findings of instability, and 81% were due to findings of actual spinal cord injury that was visualized on the MRI. So in the setting of an injury, then it is indicated and important to go ahead and get the MRI available. Looking at this SLIC score, moving forward from the initial study. So they, Samuel et al. Performed this retrospective review of 185 consecutive patients at a level 1 spinal injury referral center in Australia. And they found that according to this score, 94% of the patients were managed non-surgically, and 95% of the patients that would have been recommended for surgery by the SLIC score with 5 or higher points were managed operatively. So this fit along well with the recommendations from the score. And this was patients that had been treated before the score was published, and retrospectively applying that score and just seeing where it settled out. And also interesting, I guess, would be the number 4 scores, which was surgeon preference, was about 65 or was 65% managed operatively. So then looking forward, this study from Joaquim et al. In 2014 prospectively applied the SLIC scoring, and they ended up with 23 patients in each group, operative and non-operative, and they found that there was this was a safe application of this, and they found no unusual complications or issues with applying this score. Of interest in this paper, they did go on to talk about the anterior posterior combined score as it related to the SLIC, and they had 53% treated anterior surgery, 30% posterior, and 17 combined, and that the increasing severity of the score seemed to correlate as that no patients with SLIC were less than 6 received the combined surgery. However, the patients, as you can see here, with higher scoring had more incidence of front and back surgery. So I'm getting a little close on time here. We'll deep into those. I guess we could move more to a couple things here at the end. Say another thing that is controversial or discussed in all ortho trauma settings, but here in the spine, would be the time to surgery. Several studies have found some correlation with greater improvement in the Asia classification of their neurologic function if surgery was done in less than 24 hours compared to greater than. Did see this another recent 2020 study, however, that went seek to evaluate this further and looking at the old for early, is defined as less than 12 hours, early, the 12 to 24 hours, and late greater than 24 hours surgery in these cervical spinal cord injury patients. And they did not find any strong correlation with timing. However, they found a very strong correlation with their preoperative IML, or the intramedullary lesion length. So the length of the injury in the actual cord was the most predictive of a long-term neurologic outcomes, and they did not find as much regarding the timing of the surgery. However, the evidence, I would say, in general supports that, and unless there's other reasons that are delaying surgery, that surgery within 24 hours, I would still recommend that. So in conclusion, we want to, subaxial cervical spine injuries, we want to make sure that we have a stable spine after our treatment to ensure that we either, and a decompression as necessary to ensure the best neurologic function and then overall function regarding stability long term. So it's necessary to classify this injury, have a robust knowledge of both the anatomy and these injuries. The classification systems can help to parse that out. The initial management, the stabilization, potentially with steroids, if presenting less than 8 hours for more than 24 hours, and then the variety of injuries, which we did not have time to get into the specifics for the treatments of each injury. However, knowing these and applying both your treatment as well to either the classification system or otherwise as needed is the way I would proceed with tackling these injuries. I'd like to thank Dr. Collier, who gave a talk previously. It was helpful in me preparing mine. These are the rest of the references. I'd like to open to any questions or comments.
Great job, Andrew. It's a huge topic, and nice. We're trying to incorporate lots of information. Sorry I had to skim over some of that stuff, and I put a lot of work into that. So
yeah, thank you, Andrew. Yeah,
for sure. A lot of the controversy, is surrounded by the administration of steroids and timing, just like you said. So, given what you've read, let's say your mom has a spinal cord injury, and she presents within like 8 hours, just like you showed there. What's your ideal management for your mom?
I'd say it would depend on the specifics. Yeah, I would say initial stabilization with C-collar, such spinal precautions. I would recommend starting the steroids for 24 hours and proceeding with definitive fixation within 24 hours once the team is able to assemble in daylight hours if possible.
So do you want her in the operating room just within a day, or do you want her in the operating room immediately?
I would say within the day when the team's available. If they're available immediately, then as soon as they could be ready. However, I wouldn't want to be doing having a person who's not comfortable with the surgery or not having all the techs and X-ray and the surgical techs and everyone, depending on the center, that could be a problem at odd hours. So within 24 hours, but as early as feasible with the proper team and equipment.
Yeah, I think that's, it's okay to be aggressive with an answer if you feel like it's necessary. For instance, like if it's my neck or shoot anybody's neck, like I want it fixed ASAP as long as it's, as long as it's safe. If there's not other distracting injuries that'll cause a problem in the operating room. But all things being equal, take the pressure off my spinal cord, now. So don't delay. So for me, this is one of those, in our field, we rarely have to get up in the middle of the night to go do something. But like an acute spinal cord injury, to me, is one of those things that I'll operate at night for. I just feel intuitively, the data doesn't totally bear it out, but that's, I think, secondary also to the wide variation in trauma to the spinal cord itself. But if it's an incomplete injury, I think they should be decompressed, as soon as the OR is available. Anybody disagree with that?
No, I think that's the litmus test that we talk about, where the data is insufficient, and we all have a sort of internal sense of what the right answer is. What we do for our families or ourselves gets you through that gray or the void in the data.
Cool. Anybody else have any comments or questions?
No, great job, Andrew.